Okay, so apologies to everybody else joining in. We're getting a little late start, and apologies for not having an April conference, but the group was just a little too busy to find a common date. And in any event, I am going to go through our little disclaimer here. We're doing monthly presentations of interesting cases in audiovestibular medicine. Myself, Gerard, Gianoli, Mohamed, Hamid, and Eugen Ionescu are the hosts, but all are encouraged to participate. The information discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your own physician. While these conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your physician for individualized medical care. And we've archived our discussions at our YouTube channel, youtube.com/at AVM case discussions. And for the case presentation, I'm going to turn it over to our buddy Eugene, who is going to talk about when the nerve is normal, but the space is not. And
Can
Eugene, if you
you,
want to, can you share your,
yes, please, if you can,
go ahead.
I will try to share my, okay, now it's good, I think. You see my screen now?
Yes.
Yes.
Here we
It's
are.
okay. Good.
So, um, I will put an diaporama. That's okay. So I had the pleasure to share with you some two cases, interesting cases. First, I would like to I think that Gary recalled that in 2023, I present something. I had a presentation behind the American Neurology Society when I proposed the concept of the near narrowed internal auditory canal. In fact, I had a series large as 50 patients, which had some symptoms, audiologic and vestibular, especially vestibular signs and symptoms. And I found that because the presentation mimic and some points the vestibular paroxysmia. I performed some imaging and I saw that the internal I saw some very interesting imaging with a normal vestibular cochlear or cochleovestibular nerve, but in an internal auditory canal which was limited, inferior to 3 millimeters, sometimes around 2 millimeters. But as you know, the real narrow internal auditory canal, it's the what we can find in patients which have an hypoplastic nerve or absent nerve. And there are many articles, papers, is this like the paper of Balvasori and others described this pathology, which is very important when we to find it and to diagnose it before putting an cochlear implantation. And we have some publication, and we published some these cohorts in adults, but in children also. But as I told it, the vestibular symptoms are very often a kind of like mimics the VPPB, can mimic some, there are some vertigos or instabilities when or dizziness related to the physical exertion, and with the head turning to the left or to the right or to the right. So uh, mainly vestibular symptoms and sometimes some hyperacusis or tinnitus. So instead, there are two patients which I was very with some vestibular and auditory impairments, very important, which contrast with the slight symptoms or when with very normal, with quite normal audiologic and vestibular findings, which was in contrast with the other groups I found and I present before. So that was a hazard that there was a female and a male, both um, born in 1987. And the first, for the woman, the onset was an adult age. She had no hearing loss, but signs of bilateral vestibulopathy and a narrow internal auditory canal as fine as radiologic fine. And she was very happy with oxcarbamazepine as treatment in a discontinuous manner. And the second one, in this case, the symptoms was very, very important since the age of 7 year, and he left cathotic at age of 8 years, and that was performed at age of 15 a vestibular neurotomy because a um, very because he was very impaired by the vestibular symptoms. Also after the neurotomy, he had balance problems for more than 20 years. And finally, I found that he had a very narrow internal auditory canal. I will show a little bit with other slides.
Eugene,
Um, yeah.
how was the vestibular neurectomy done in the 15-year-old? Was it a
Yes,
suboccipital or?
yes, finally, as I will show you, that was not a retrosigmoidian approach. There was a translabyrinthine, and
Right.
finally, there was not a real neurectomy, but they precise that neurectomy, and you'll see with the imaging. I will show you. So as I told it, this is the first case with the who was she had no the physical examinations were not very but not well modification important for, as you see here, but I shall go straightly directly to the and you will see here, you can observe here that she had only right, left horizontal nystagmus at the video nystagmoscopy and video nystagmography. She had a very poor response at the caloric tests, and in the hip was nearly normal, but the shimp was the gain was diminished, as you can see here. And we observed no response to the cervical vamps. The only modification was the BAR, the brain evoked auditory response. We observed a slight but bilaterally pronounced 1 to 3 interwaves. But and strangely, when you see the on the posterographic assessment, the postural control was not very bad. Instead, when you looked here, when we look to the scan, a CT scan, we observe that in the axial plane, this was quite normal, except this cochleofacial on the on top at the right, cochleofacial descent, but she was not complaining. She had no signs of third window, no otic capsule dehiscence. But in the coronal plane, both at the left and on the right, we can observe that the um, internal auditory meatus was measured to 2.6 to 2.7 millimeters, as on the MRI in is the same patient, of course. And as the treatment with beta-histine would not benefit from more than 5 months, we started treatment with the neuroprotection with trileptal oxcarbazepine, and we had a very interesting evolution, and the patient was very well after 3 months of treatment. And as you observe here, I was very interested to see if I can observe a evolution in the BR aspects of PAM pattern. And also we have observed after 6 weeks of treatment of a little bit amelioration when we controlled the BIR. After a while, she get worse. She would get worse in considering the BIR, but clinically she was very fine. So the second case, and the second case, as you understand already, it's a very long. It's a patient, a very young patient with a very um, um, it's very symptomatic from a auditory point of view, but vestibular also, as you can observe here. And the what was very embarrassing, I think that at the age of 15 years old to be operated and to practice, say, a labyrinthectomy, it's not. Oh, you
Jeez.
see, it's not a very good, not with a very good follow, and not was not very comfortable issue. He was supplementary. He was when he came to us in 2023. He had also experienced that fluctuation on the right ear, on the good ear, and as you can observe here, there was a little fluctuation mainly on the in 2025 we measured hearing loss on the high frequencies. Also, you can observe here that what was presented, what is called like a neurectomy, we observed that it was reflexive on the caloric test. On the high frequencies and the head impulse test, was the gain were not zero on the right, but on the CVAMs were absent on the right side. And when you see this MRI in coronal plane, what did you, what is your feeling, guys? I measured him at 1.3 millimeter.
Pretty darn narrow.
Yeah.
Yeah, it
And
looks like the
this is
nerve.
on the right side. We are on the right side here only.
Yeah, it looks like the nerve takes up almost the whole entire IAC there.
Yeah. And there is in contact between the bone and the nerve. And here are the measurements You see that an axial plane, and we can observe the nerves. And my colleagues, radiologues, performed. They didn't observe some signs of degeneration of the nerve, of the hypoplastic, etc. Instead, they were astonished by this dimension of the internal auditory canal. If we have no MRI, we could expect that this guy, the guy, he have no acoustic vestibular nerve. Have you seen some images like that, Gerard?
Yeah,
And
no, I actually had one not too long ago that in after you told me you were giving this
yeah.
presentation, I came across one. And the first thought to my mind is what's the mechanism for progression or onset of loss? And I think you alluded to it earlier, but I'd love to hear your thoughts on that.
Okay, that's a good point. I prefer to show here that my colleagues, radiologues, made some measures and told me that the nerve it's present, it's well, it's not there are not signs of degeneration. But yes, I think that how when the subject it's very young, I think that we can observe a normal vestibular and auditory function. But as I told you, I had some cases. We had some cases in young adults for I don't know maybe for 4 5 years to 10 years old, and when they became to cross, when they became adolescents, and I think with the cranial, with the general um, development, I think that may be a mechanical stress at the level of the meatus acoustic intern, internal acoustic meatus, which will stretch the fibers. I think that it's pure mechanically mechanism, and also to the cranial development. It's not very important still. Uh, there are some modifications, and in this case, we can observe some symptoms occurred starting with the age of 10 or 12 years old. And I have no other explanation, uh, but I know now. I'm definitely know because I have very much. I observed in my series now. I think that we have more than 100 patients to which respond very well to the generally to up to 95% with the treatment of neuroprotection. It's incredible. And we have some young adults and children still, which was initially, I think that you have the possibility to observe also or to diagnose young children with there is the benign vestibular paroxysmia in children, which is not autolytical, which is considered as a migrainous mechanism. But I had done so with internal, with some children with narrow internal auditory canal, which respond very well to this kind of vestibular symptoms with neuroprotection. And so the second case also respond very well. Now I call him now a week, and it's on gabapentin, he did not have any instability and vertigo. And what is interesting that this kind of patient, and is the third one in 2 weeks, he told me that I completely changed his life, and it's very impressive. And when
Wow.
you heard something like that,
Absolutely.
so uh, that was an. I don't know that I show. I think that I have another imaging now, but there was not a complete section of the nerve. We can put the results, which was not very good, on this because it was not a real neurectomy. There was a labyrinthectomy and so a distraction, partial distraction of the vestibular, um, with conserving the cochlea. And even with he was kyphotic, he had some perception, very disgracious perception on the left side, which ameliorated now with this treatment. I don't know, it's subjective, but it's very interesting.
It's interesting.
Um, so my conclusion is that we have you can see here on the left this imaging for the woman and for the young the other patient, because both are the same age finally. And my opinion is that I was very impressed. I didn't consider that till now 2 3 months 2 or 3 months, that an internal auditory canal reduced, even like in the second case, could be a cause, could be an etiology, and in case of bilateral vestibulopathy. But I think that it's a kind of um, it's a kind of challenge we must try to find out. The, of course, there are some questions. I'm thinking now. I saw some patient, and I have some friends from and colleagues from Romania and in Italy. They asked for me and see. It's not a conclusion. Of course, we must look about how the nerve, the paths of the nerve, when we have some to deal with some patients with symptoms which not are very suggestive of Meniere's disease, for example. You recall the guys that I presented now some months ago, a patient which had a very clear manifestation of Meniere's disease, but finally there was this exostosis of the internal auditory canal. So I think that we must look after this presentation, and I was sure that I was maybe the first, or we have our team for the first in the world to discover. You see the comas,
Wow.
this pathology, but I look well in
Wow.
I don't find it on the internet. I was obliged to go and find this work of Phelps in 1975. This is not. I don't find it on the internet, but with the radiology tomography and the Stanver's imaging, etc. And he put it here, narrow end of the internal auditory canal, less than 3 millimeters. Exactly as I put it, may generate symptoms which can mimic Meniere's disease. And this is another team from Italy, and they published in 1979 the same thing, and they proposed to a decompression or vestibular neurectomy. So this was my presentation, and here there are other patients. I was I was I was demand to make an opinion, and look what I found here. Another patient with millimeter and in bilaterally. Generally is bilateral. So thank you very much, guys. If you have some questions, I
That's a great presentation, Eugene.
Yes.
I like your discussion questions. Do you want to go back to those discussion questions?
yeah,
Because
I must go. Yeah,
uh,
here. It's okay.
yeah, I think, I definitely
Shoot.
think this is
Everyone
something.
shoot.
Yeah, I was just say I definitely think this is something that's underdiagnosed. It's one of these things that unless you're actively looking for it, you're not going to find it, I think.
Yes.
And I think it's one of these, it's another one of these, what is it? Mo, is it the red Cadillac syndrome? Y'all familiar with that? Where, you buy, how many red Cadillacs have you seen on the road lately? And the answer is no. But if you buy one, suddenly you see them everywhere. And it's kind of the same thing. It's like not until you're aware of it do you actually even notice it's there. Um,
Yes.
but I'm interested in this whole issue of you mentioned, was this ever Meniere's disease? And I think one of the problems, and we've talked about this before, is our propensity to label syndromes rather than get to the heart of what's causing the syndrome. So
Yeah.
I guess the answer is, was it ever Meniere's? The question is, well, it could have been a Meniere syndrome caused by a stenotic internal auditory canal would kind of be the answer I would give for that. But I think it goes. We talked about three PD as a diagnosis and Meniere's as a diagnosis, as well as a bunch of others. And I think those are more syndromes, and we got to look below the surface to see why they have those syndromes.
Yeah.
Um, Mo,
Is
your
the second
thoughts?
patient, the second patient, no, the first patient was labelized PPPD because she meets the criteria. You
Yeah.
know.
Yeah.
Yeah, but
But
was it ever, this is a great discussion and there are many questions. I think my first question is, nowadays people don't jump quickly to vestibular neurectomy and definitely in a
Yeah.
younger patient without really documentation according to the dates. It was only 1 year with no diagnosis. Disabling vertigo, that is usually um, the primary ground for neurectomy was not established. So that's number one. Number two, I'm kind of curious that using anti-epileptic medications have actually improved them, which brings the very old maybe literature that was talking about vestibular seizures. Did any of these patients have EEGs, Eugene?
no, because they have no expression, no, they have not the only I think that the only diagnosis which would make sense to split to differentiate from neurological seizures was the partial crisis because
Hmm.
there is no lose of consciousness, never, and the crises are repetitive, very short, some only some seconds
You know,
generally.
I'm going to jump in here. I'm
Except the
going to
distance, except, excuse me,
I
except
mean, we
the
can call
distance.
it vestibular paroxysmia, which
Yeah.
honestly we don't know the underlying etiology. So, could it be a different kind of seizure that need to be considered? I think so, but
So,
I don't have
Mo,
enough data to
I
prove
got to
that.
jump in here. So, think of it this way. Okay, what is a seizure but an a random burst of electrical activity in part of the brain, right? Well, let's say we're having a random burst of electrical activity in the vestibular nerve because it's being
Right.
stretched. In some ways, that is a vestibular seizure. I mean,
Yeah,
if you think
it's a very
about it,
good
I mean,
point.
we're talking, it's a little bit semantics, but and to me, that makes sense if you can calm down the
Yeah.
nerve with an a neuroleptic medication, whether it's caused, somewhere further, here we've got an anatomic spot that looks like, this looks like a spot that's being aggravated with, as the brain moves around, it stretches the vestibular nerve. I think this is really interesting, and it certainly enhanced my desire to look more for this. Now, I do have a question. So, Eugene, in your mind, the things that make you suspicious for this is somebody who presents with a vestibular paroxysmia type presentation and has an abnormal auditory brainstem response.
There are in our series, I think that there are even patients with no auditory symptoms. We practice ABR and we observe that 40% approximately, they have an interval, interwave interval 1, 3 superior to 2.3 milliseconds,
Hmm.
and we consider them pathognomonic, as as the works of Janetta and how it's called, the Janetta and
Bola
I don't recall his name now, but
begins with an
I
M.
Yeah. Yeah. Yeah.
sorry.
Begins with an M. I know who
Yes,
you're
I
talking
think
about, though.
yes. So we consider that, and we observe sometimes the ameliorations of the pattern of this interval with the treatment. It's very interesting. Uh, and to be honest, now 20 years ago, everybody, and we are in France, guys, everything was mania-like crisis, uncommon form of mania disease, and I was very because I and there was a resistance even behind the forms of a form of vestibular paroxysmia, clear. And donc, in France, there was a kind of every patient with vestibular symptoms was considered to be a mania or mania-like syndrome, but not
Yeah.
retrocochlear causes. And I try to see a little bit different, and I start to look myself the MRI. And I observed that in some cases, some many disease-like manifestation, in fact, were related to this narrowed internal auditory canal. Is there so in and especially guys in coronal plane,
Hmm.
inferior to 3 millimeter, should think to that. And after, I don't think that is, I think that it's a local neuropathy. As in case of foraminal for the for the sciatics. So the sciatic nerve is very important. I as I practice as a neurosurgeon now 25 years ago, I was astonished to observe some everybody thought, you have a sciatic, but in fact, and hernia, and discal hernia. But
Yeah.
when I looked in the etiology of the sciatics, there was some cases of compression by the venous plexus on the sciatic, which generate nocturne and the night sciatica, you know. And by assimilation, I thought to myself that it must be something which, in then when you looked at the internal auditory canal, I thought I told to myself that must be something which is not mania disease here.
Mhm.
And I think that, and I don't think that is a crisis, not vestibular crisis, epileptic as origin, because the doses of oxcarbamazepine is very, very low. It's one third in children. We give up to 150 milligrams a day, maybe 300, but no, 300 is fair for the adults, in adults. And the doses for as an anti-epileptic drug, it's 1 gram for a day. So it's five, six, four, six, 5 or 6 um, um, times more important as doses.
You know, I'm interested in your last question about should neurectomy be contraindicated with which I have to admit, you know, I in my early career I did a lot of vestibular neurectomies and a lot of labyrinthectomies, and I can't tell you the last time I did a vestibular neurectomy. It's been forever. But the question I have for you is suppose you have a patient with narrow IACs and they don't respond to the neuroleptics. Do you think that's someone you would consider doing a decompression on? And then the second question would be, how would you do this decompression? Because I think a middle fossa decompression wouldn't make any sense. You know, it would seem like you'd have to get the inferior IAC decompressed.
Um, I will come to this. I will try to. Yes, I think that in this presentation, we can. You see my screen?
Yes, sir.
You yeah.
Mm-hmm.
In this case, in the middle, when we saw that there is a kind of hyper pneumatization of the temporal bone. In this case, I think that the compression is here on the MRI. We see the contact between the nerve and the bone. I
Mm-hmm.
think that we might try, but I think that the that we should use a special drill, and we must avoid the caloric effect of the drilling, of the approach, etc. I think that we might try, as in case of exostomas, of the internal
Mm-hmm.
auditory canal. But I think that in the other presentation, like this, is very difficult because, uh, like in this one, in the second image, and you know, you see that the it's funnel. It's not. It's not like a local compression. I don't know. I cannot pull. I think that I can not indicate a surgery in this case. But
The other point, I'm sorry, go ahead. I didn't mean to interrupt you, Eugene.
no, no, it's okay. Please.
Yeah. This deficit is from day zero after the patient is born. So vestibular compensation took place. So why is it that we're not really seeing evidence of objective, and we have to be careful here, difference in the vestibular compensation in these patients? Because they shouldn't have any objective evidence unless there is another
Yeah.
disease on top of the compression.
Yes, I think that the myelin, the gain of myelin, it tend when we are young, it's okay, but with the age, the texture and the resistance is not very, it's decreasing. That's why the compression, as in case of the cross compression of the trigeminal nerve and another cross compression syndromes, we know that the period the is when the patient became symptomatic, it's more like in the fourth, fifth, and sixth decade. So
Okay.
this is in relation with two elements. One is the gain of myelin. It's not so good, it's not so protective, and the vessels became a little bit more rigid, and the contact between the vessels at the interface before between the nerve and the artery, it's more traumatic for the nerve. I think that it's the same, even if there are some children with this kind, with adults and young adults with symptomatics, they are less than those ones of which became symptomatic at 15, 16 years old. I have many patients in this of this age. So I think that it's a problem of the, it's not a question of the progressive, maybe sometimes there is a progressive vestibulopathy, but I
Hmm.
think that symptoms are more often in after 15 years old.
Yes, I completely agree with that. But interestingly, on the postography that you showed on, I
Yeah,
think, patient one,
Yeah.
this has what I really termed aphysiologic sway pattern. So these patients develop, in my opinion, a sense of fear of motion. Yeah. So if we go back to that uh, postography, it's
yeah.
definitely some. I mean, on one and two, patient is not able to do anything, but on three and four, which are supposedly more difficult, is doing
Yeah.
fine.
Yes, very
So
fine.
yeah, I think these patients need, obviously, in your institution, they get the right evaluation, and we have to be a little open here. These patients, if they got rushed into surgery unnecessarily, I think it is because the workup has not been completely done by a vestibular medicine specialist. What do you
Yeah.
think, Gary,
Yeah.
as well?
Yeah, I think again, the older I get, the less I'm inclined to do any kind of deafferentation unless everything else has been tried. I've
Yeah.
also gotten more and more conservative with just a lot of the mainstay surgical treatments until you've really exhausted medical means. And I think the further I've gotten in my career, we've developed more medical treatments for things and more non-destructive surgical treatments to where I'm really loath to do that because it's like you see this young kid who's had a labyrinthectomy and that wasn't even addressing the real pathology, which was more proximal at the vestibular nerve. And I agree
Yeah.
with you. It could be he's still getting stimulation of that vestibular nerve, even though it's not attached to any sense organ on the other side.
Hmm.
Um,
Yeah.
but
And
the further I get into this, the more I want to know before I do any kind of treatment. I mean, I want to know everything, all the different function. And I don't see how these folks can treat patients without any kind of vestibular testing. I really
Mm.
don't.
Good.
Yeah.
Yes, and vestibular testing complete and accurate as well. I have to say that
yeah.
because
But the
you
the
know
point you made,
uh, uh,
yeah,
there are a lot of vestibular nerve sections still being done globally, and I think they need to be kind of reconsider the true indication for the surgery because it's a one-way street.
Yeah.
And because you are here, we are here. Uh, when the very first time when I start to put some questions, I have a Meniere disease here, where it's a patient that they made Meniere disease with everything. It's it's linked or not. Because there are some papers which reported that after
Yes.
neurectomy for mania disease, they studied the nerve, and the nerve was the vestibular nerve. There was some cases, listed half, if I recall correctly, which signs of neuropathy. And if neuropathy is what is, and I was thinking to my patient which develops the Tumarkin crisis. I referred to the colleagues for to perform neurectomy, and I have done so. I think 8 or 9 patients, which I recommended finally, because they don't respond to, with the gentamicin.
Gentamicin. Okay. Thank
Gentamicin, they
you.
didn't respond. They cut the nerve, and they was ameliorated. Okay, but I saw that on the response of the anatopathology, that was effectively some neuropathical modification on the nerve. And starting with that day, I have now 3 patients which so-called Tumarkin crisis, which responded after I tried, and with no response, a very good response with the Gentoline, and they responded at, what do you think, guys? To the Neurontin, to gabapentin. So I don't know that it was a link between a mania disease with discharge in the nerve, some atypical firing in the nerve, and could explain some ectopics and neuropathic modifications on the vestibular nerve. I don't know, maybe we should consider a pathology like Gen style, I don't know, neurovestibulopathy or vestibuloneuropathy.
Mhm.
Well, let's
Yeah.
think about this for a minute. As far as identifying vestibular or localizing pathology to the vestibular nerve, really, we don't have a lot of good stuff for that. We've got the ABR, which is checking the
Mm.
cochlear nerve and seeing if it's got some, pressure on it
Indirectly.
as well.
Mm.
We've got all the vestibular tests, which you can't extract from the end organ itself. You can't say it's end organ versus the nerve. And so then we got the anatomic studies, which are the MRI and the CAT scan. Um, you know, so the biggest issue for me is going to be, really we don't have great, localizing testing for the
Yeah.
vestibular nerve. I think you can infer it when you got a whole bunch of other tests and it's just more pointing to the nerve versus something else. But I think the best thing we got going for us is just the anatomy. It's like you were seeing on your CAT scan showing narrowed, nerves. I mean, I guess let's think about this. Theoretically, you could have a normal size internal auditory canal. Let's say you got a 6 millimeter diameter or
Mm.
coronal diameter. But if that inferior lip sticks up, you could
Mhm.
Yes,
potentially
I
have
had some cases like
tension
that.
there
Yeah.
with no stenosis. And I think the only way you can potentially prove that is with anatomic studies showing the nerve kind of stretched, or
Tractography.
an ABR
Yeah.
is about it.
Yeah.
Mo, the point you made about compensation is so important. I mean, in both these cases, these are long-standing cases. The patients, well, as evidenced by the posturography, have compensated very, very well. So any further intervention, whether it's deafferentation by a surgeon, or whether it's just something that happens down the line, is going to cause them not to compensate, but to have to uncompensate and then recompensate, which is a hell of a lot harder to do. And
Mm.
that could be a reason for their recurring complaints. It's not something new. It's just sort of a decompensation. So the bottom phrase here, should neurectomy be contraindicated? I would think it should, as a non-surgeon, it should be contraindicated, because which side are you going to do? If you've got bilateral disease,
Yeah.
which side are you going to do? And what happens if something disrupts the other side later on? That's a question for the Dr. Gianoli, who's seeing me and telling me I've got bilateral disease. How do you pick which side to do? How come you're doing it? And what happens if something goes on the other side in 5 years' time?
I totally agree. I mean, that's why I'm very hesitant to do any deafferentation.
Nice.
Even if it's obvious unilateral disease, I'm hesitant to do it for fear of what happens if the other side develops problems.
Yeah. And you're changing the situation for which the patient has already compensated, hopefully reasonably effectively. They'll never be an Olympic gymnast, but they'll be able to live their lives.
Absolutely. Yeah. Absolutely. Well, guys, it's been great meeting again. I'm sorry we had such a delay. I have to move on because I got another conference butt up against this one. We don't have a date for June yet, but we need to kind of come up with that. And I'll send out the Zoom invitations to everybody when we get our date together.
Okay.
Perfect.
Great
Thank
presentation, Eugene.
Yeah,
Yes,
thanks, Gene. Very interesting.
Thank you.
Okay.
Yeah.
Okay.
Thank you,
Thank you, guys. Bye-bye.
Okay. Bye.
Okay.